My name's Jem Patel and I'm the Global Scientific Advisor. In our inaugural video, we will be reviewing the Hanania et al. 2018 publication. This publication focuses on the measurement of fractional exhaled nitric oxide in a real-world setting. By way of background, assessing asthma using only clinical measures such as spirometry and symptoms often fails to detect the underlying airway inflammation. Measurement of FeNO levels, a recognized biomarker in type 2 asthma, can be useful in assessing steroid-responsive type 2 airway inflammation. FeNO testing is quick, non-invasive, and can be assessed at the point of care. FeNO has a high sensitivity and specificity for asthma and correlates well with induced sputum eosinophils and bronchial hyperresponsiveness. FeNO can help to predict steroid responsiveness and help optimize therapy, and can also help to uncover non-adherence to steroids. Despite these benefits of measuring FeNO, its impact on treatment decisions made by clinicians is rarely reported. So as part of the objective of this particular publication, the primary objective was to determine the impact of measuring FeNO on asthma management in the real-world setting. US asthma specialists, so that's the allergists, pulmonologists, but not primary care practices, were previously asked to participate in this study. And 4 questions were asked. The first is simply the clinician's assessment of the patient's airway inflammation. This was done after the usual clinical assessments, not including FeNO. In this first question, inflammation was classified as either low, intermediate, or high. The second question asked the clinician to document the medications that were prescribed to the patient. Next, the patient underwent FeNO testing. After being made aware of the patient's FeNO levels, the clinician had then the opportunity to alter the patient's treatment plan. Question 3 asked if there were any changes that were made to the patient's medication. And finally, question 4 documented any changes that were made, including starting or stopping medications and increasing or decreasing doses. So just to highlight, in terms of demographics, 337 US practices participated in the survey, of which patient numbers were totaling 7,901, and all these patients were over the age of 12 diagnosed with asthma. So if we refer to Table 1 from the publication, we can see that clinicians assessed airway inflammation as low in 53.8% of patients, intermediate in 34.8%, and high inflammation in 11.5%. The FeNO assessment levels were classified according to the ATS cutoff values, and by that we mean that low was assessed as less than 25 parts per billion, intermediate was between 25 and 50 parts per billion, and greater than 50 parts per billion was assessed as high. Across the full analysis set, the clinical assessment of airway inflammation matched FeNO classification in slightly more than half of the patients. Within the high inflammation subgroup, a FeNO level of greater than 50 parts per billion, clinicians' assessments matched the FeNO category in only 1/3 of these patients. Airway inflammation, it seems, more often than not, was underestimated. Now, in this slide that we're showing you, this data was not charted in the paper, but after reviewing the FeNO measurement, clinicians indicated that they made changes to the treatment plan based on the FeNO value in 30.7% of patients. They made no changes in 66.5% and left this question blank for 2.5%. Of the patients in whom treatment plans were changed based on their FeNO measurements, most, or 68.4%, were in the high inflammation subgroup, followed by the intermediate inflammation subgroup at 46.1% and 17.8% in the remaining low inflammation subgroup. Now, consistent with recognition that FeNO values reflect type 2 airway inflammation and corticosteroid responsiveness, 89.7% of changes were made to the treatment plan and involved corticosteroid medications. In the overall patient population, corticosteroids were either initiated or the dose increased in 21% of patients and either discontinued or the dose decreased in 7% of patients. Corticosteroids were stepped up in 66% in the high inflammation subgroup compared with only 5% in the low subgroup. Conversely, corticosteroid doses were stepped down in only 9% of patients with low inflammation and in 2% with high inflammation. So by way of discussion, in this survey of real-world clinical practice, the investigators found that measurement of FeNO by clinicians who were previously naive to measuring FeNO markedly influenced clinical decisions, making and resulted in the alteration of treatment plans for their patients with asthma. Although the relative proportion of patients having been assessed as having low, intermediate, or high inflammation was similar when assessed either clinically or by way of FeNO measurement, the agreement between the two methods was only 56%. So in this present analysis, the addition of FeNO measurement in addition to clinical assessment resulted in alterations to the treatment plan for nearly 1/3 of the patients that were assessed. Most medication changes, so about 89.7%, that were made based on FeNO measurements involved modifying the dose of corticosteroids. For the high inflammation subgroup, clinicians stepped up corticosteroid treatment in approximately 2/3 of these patients, and for the remaining 1/3 remained unchanged. Potential limitations of the analysis reflect that it was designed in a non-randomized cross-sectional survey of real-world practices. The design limitations inherent in any real-world analysis do not control the potential selection bias or allow conclusions to be drawn about the effect of FeNO measurements on asthma outcome. Based on the results of this real-world survey of clinicians' practices, the authors suggest that FeNO measurement provided additional important information that complemented usual clinical and physiologic assessment of patients with asthma. Clinicians in routine practice who were previously naive to FeNO measurements used the FeNO values to alter their treatment decisions, generally preferring to step up anti-inflammatory therapy in patients when high levels of T2 inflammation were present or recognized. The increased identification of patients with high levels of airway inflammation that is not apparent from clinical assessment or spirometry is a striking finding from this survey. This suggests that more widespread measurement of FeNO would help identify patients with type 2 asthma and high levels of inflammation who could be at risk of future exacerbations. So by way of conclusion, measurement of FeNO enabled clinicians to assess underlying airway inflammation, leading to a significant revision of their treatment plans compared with real-world clinical assessment of asthma alone. Thank you for joining us on our inaugural video, and we look forward to welcoming you for future videos in this series.